Welcome to video 2. In this video, we'll continue to look at new terminology regarding randomized controlled trials, more specifically related to the design and conduct of the study. Let's review some key components of randomized controlled trials that we learned back in lecture 3. Randomized controlled trials work by collecting a group of individuals, so your sample population, and then assigning those individuals to receive a particular exposure, and then following them to the development of the outcome. RCTs are classified as analytical studies because they always are designed to assess a relationship between intervention and outcome. They're prospective because we're following patients forward to the outcome, and they're interventional because we're assigning patients to either be on an intervention or in a comparator group, as opposed to case control and cohort studies in which there's no assignment by the investigators. Patients instead are assigned themselves to the groups essentially because they're exposed or unexposed or have an outcome or don't at baseline, and the investigators are simply measuring them. In terms of causal assessment, our RCTs are considered the gold standard study design and the only study design that can be used to firmly establish causal relationships because they fulfill our 3 causal criteria: experimentation, directionality, and individual association. In the RCT that we're going to look at in detail, I've outlined the basic schematic of the study from a total population of non-Hispanic Black men. We chose Black men in LA who specifically attend barber shops. The investigator then randomizes the barber shops, so it's going to be a cluster randomized trial to either have barbers, which refer patients to a specialty pharmacist, or who refer patients to physicians. The investigators then follow these patients forward for 6 months and compare the blood pressure. And our final review slide. If RCTs are so great, why aren't all studies randomized controlled trials? Again, this comes down to 2 major components of ethics and feasibility. Ethically, if we know a treatment to be harmful, it's unethical to randomly assign patients to receive the treatment. For example, cigarettes are known to be harmful, alcohol is known to be harmful, cocaine is known to be harmful, so it'd be inappropriate to assign half of our patients to receive that harmful treatment. The other major component is feasibility. Randomized controlled trials cost lots of money and are often very long in duration, so it's prohibitively expensive to randomize more than 10,000 people or follow patients for long periods of time, unless essentially you're a pharmaceutical company. Also, some exposures cannot be randomly assigned, like if you're interested in knowing the effects of combat on military personnel or the impact of natural disasters. Other things include, you can't randomize people to be on Facebook for 12 hours a day. In these situations, you must do an observational study. Let's talk a little bit about conducting a randomized controlled trial. In order to perform a RCT, you must submit a detailed description of study methods to an IRB or institutional review board, and more recently, publish this protocol on a public domain. So it's important that the scientific community knows what you're going to publish, that you're going to publish a randomized controlled trial or conduct one, so then you're held accountable for publishing the results and you can't avoid publishing negative results. Like I said, this is a fairly new development. For study methods, they essentially consist of a study protocol, which tells us about what the design of the study is, the specific treatment regimen for the patients, how blinding is employed, the method of randomization, which outcomes you're looking at, and which is the primary outcome versus the secondary outcomes, and the specific variables, again, that you're measuring, the endpoints or as baseline characteristics. The methods section should also talk about the population that you're using. So what is the population that you're after and how are you drawing your sample from that population? This is about inclusion and exclusion criteria. It should also include the time period through which you're recruiting patients and how long you're going to follow the patients. Finally, in the methods section, there should be some discussion of the statistical analysis. We want to know your type 1 error rate, your type 2 error rate, your power to detect a significant outcome, the sample size that you'll need to enroll to achieve your power, and the specific statistical tests that you're going to run for your outcomes between your groups. This is a slide that delineates the study protocol that you'd have to submit to an IRB if you were to conduct a randomized controlled trial. I won't go into everything in detail. It's more for informational slide, just to kind of display how much detail you need to go into with an IRB prior to conducting a study. So everything from study objectives to design through the safety and effectiveness assessments, to how you're going to report adverse events, how you're going to control and store the medications, and then your references. All of this needs to be submitted through the IRB and be established ahead of time before conducting the RCT. After developing the protocol, another important component of the methods of an RCT is selecting your specific population. Remember that in a study, we're trying to make inferences on a total population that has the disease of interest, but we're only able to take a small sample of that population in order to actually study. So because we need to take a small sample, we need to have inclusion criteria, which are essentially the factors by which we're going to choose a sample from the total population. These are just qualifications of the population that we're enrolling into the study. For the study that we're going to look at, it's essentially going to be non-Hispanic Black men living in greater Los Angeles area, and then also being a frequent patron of a barbershop. The exclusion criteria are factors and individuals which would exclude them from the study, and they're usually factors that would confound our ability to interpret study results. We talked a little bit earlier about how we probably wouldn't enroll hemophilia patients into an anticoagulation trial because we'd be interested in knowing how much anticoagulants increased our risk of bleeding, but hemophilia patients may bleed for their own reasons. So we want to exclude them because they have the ability to confound our results. The final component of population selection has to do with recruitment, which is the description of the methods that were used to enroll patients into the study. And obviously these methods will be based on inclusion and exclusion criteria. They're also an IRB requirement. Recruitment should also list factors such as the time period through which the recruitment process is occurring. Loss to follow-up is a very important consideration in randomized controlled trials because we want to be sure that we get outcomes data on everyone that we enroll in the study. We use patient flow diagrams in randomized controlled trials to account for every single patient that was enrolled in the study. So at the top of this diagram is how many patients that we first assessed for eligibility. So these should be patients that meet our inclusion and exclusion criteria. And only after meeting those criteria do we randomize them into 2 or more groups, depending on our study. Many of them will be allocated to the intervention, and then the rest will be allocated to the control group. We go through how many actually did receive the intervention and how many were stayed in the control group, and then how many were lost to follow-up in each arm, how many were analyzed in each arm. And it's charts like these that are really useful for assessing attrition bias, so how many patients are falling out of each arm, and if there's a significant difference in how many patients fall out of each particular arm. Another slide that should be reviewed for us at this point is control selection, and there's 2 main methods of using controls in RCTs. One is using a placebo medication as a control, in which control patients receive a placebo and should really only be used in cases where there's no effective treatment that already exists. Otherwise, it's unethical to give a placebo. We should be using best current care. In that case, it's an active control. An active control is giving patients an alternative medication that is best in class or usual care, which means that although there's no medication, say an antidepressant versus psychotherapy, psychotherapy is best usual care outside of a medication. There are also 2 major ways to classify study design in randomized controlled trials. There are parallel studies and there are crossover studies. In parallel studies, patients are randomized to intervention or control groups and remain in that group for the duration of the study. So for instance, if you're enrolled in an intervention group, you're in the intervention group the entire time. And if you're in the control group, you're in the control group the entire time. You can see that the 2 groups kind of go in parallel with no crossing over throughout the study. This is probably the most common type of study design. The other type that we'll mention is a crossover study, in which each patient in the study is going to receive the control and the intervention in a specific sequence. So if you start in the intervention group, you'll take the intervention for a couple of weeks or however long the protocol specifies. Then you'll stop the intervention. You'll wait throughout a period called a washout period in which the medication leaves your body. And then for the latter half of the study, you'll switch over into the control group. In a crossover, you can serve as your own control because you've had both the control and the intervention. Same goes for the opposite way. If you start in the control group, you'll wash out and then you'll end up in the intervention arm. Crossover studies are sometimes used for things like sciatic pain, for which there's no great medication right now. We can give you a neuropathic pain agent for, say, 3 weeks, assess your pain scores, wash out, or wait till the drug leaves your body, and then give you a placebo the rest of the time, and then compare how much pain you were in while you were on the control versus while on the medication. There are also several methods for analysis in randomized controlled trials. The most important one, and the one we need to make sure that investigators do in every study, is called an intention to treat analysis. This is an analysis in which everyone assigned to a particular treatment group is analyzed as part of that group. So if you are randomized to receive placebo, you're analyzed with your outcomes as a placebo patient. If you are randomized to the intervention, you are always analyzed as an intervention patient. The kind of catchy phrase for this type of analysis is called analyze what you randomize. So the fact that we're making sure that we're keeping patients in their own groups ensures that the baseline characteristics stay balanced between the groups. This also means that if you were in the intervention group but you only took one dose and then you left the study, your outcomes are still analyzed as part of the original group. The other method of analysis is called a per protocol analysis, and this is done only in subjects who complete all aspects of the protocol. If you are non-adherent to the study medication, you won't be counted, but you would have been if we would have done an intention to treat analysis. So intention to treat is more of a real-world analysis, whereas per protocol analysis shows the intervention in the best case scenario. Another type of analysis that you may see is called an interim analysis, in which study endpoints are assessed partway through the study to see if the study needs to be ended early for either efficacy or safety considerations. Finally, the last terminology that we'll learn in this lecture is on this slide, and it's called run-in phase. In a run-in phase, it's a comparative study where all participants take the intervention to ensure that they are able to adhere to the regimen and tolerate it. Following this period, or this run-in phase, participants are then randomized to control and treatment groups. This is done to ensure everyone can tolerate the medication, but it also means that the medication may appear more tolerable than it actually is when the study is done, because patients with obvious side effects to the medication who would fall out in the run-in phase are not included in the actual study. Say you wanted to study aspirin versus placebo, you put everyone on aspirin. If someone bleeds on aspirin, maybe you exclude them from the study, so then that bleeding outcome won't have been in the aspirin group. An effectiveness study is something that assesses the medication in a real-world scenario. So does the drug work in a broader population? An efficacy study is a study that assesses a medication in a study scenario. So in a very hand-picked select sample, does my drug behave as I think it should? Does it improve outcomes? Typically, an efficacy study is done first in a very small sample or a very rigid randomized controlled trial, and then you do an effectiveness study on a more real-world population to say, how would it actually perform if it comes to market? In the next video, we'll be looking at a specific randomized controlled trial.